That's right, Matangi. It's not cholestatic. Okay. Rather, what I'm seeing well here is AST and ALT are elevated. Therefore, it's hepatic. And of course, I see that the liver function has been affected. Now, as I'm looking at my liver function, I see decreased albumin, I see increased prothrombin time, and I see increased blood ammonia. And normal albumin should be anywhere between 3.5 to 4.5. So definitely decreased synthetic capacity. We have the increased PT compared to the control, and I showed you the increased ammonia. Fine, so now I want to work on this. I tell you who we can get rid of already. We know it's not cholestatic. So I'm going to kill C because severe hypercholesterolemia, that would have been a great way of getting gallstones. And gallstones, it would have increased alkaline phosphatase. It would have been cholestatic. I know I can get rid of anti-PDH antibodies. These are AMAs of PBC, primary biliary cirrhosis. That would have been cholestatic. And who tends to have a history of ulcerative colitis and positive ANCA and is also with a cholestatic jaundice? Not sure? That could be a patient with primary sclerosing cholangitis. Do you remember primary sclerosing cholangitis? And all three here, there would have been cholestatic jaundices. So it does leave me, indeed, with choosing between A or B. And of course, I forgot to show you the results and that we have, but we have by far B. Now, both A and B would have been hepatic. What is it that makes you decide B? Macrovesicular steatosis, micronodular cirrhosis, of what as a cause? Alcoholic liver disease. Whereas IgM anti-HAV, that would be a viral hepatitis. So I do agree with you. I'm going to choose B because in viral hepatitis, the increase in AST and ALT is generally greater than 500 to 1,000 units. And in alcoholic liver disease, not only the elevation is less, but more relevantly, AST is just about double the ALT level, making it very, very classic. Is that okay for everyone on how to work with the data so that we build a tree of decision on how to work with that data? Yeah? Because we didn't have as many of us going into the polls there, so that's why I'm asking. I'm just in case. So look, here's the issue. Shall we make it? No, we'll do another question after. That'll be fine. So imagine that you have a patient with jaundice, and let me insert a couple more. Make sure we're okay here. You start with jaundice and icterus. And we said, first thing to do is check bilirubin. And when you check bilirubin, It's either going to be primarily unconjugated, which really honestly has few etiologies, or it's going to be primarily conjugated or mixed hyperbilirubinemia. So indirect versus direct bilirubinemia. If it's primarily unconjugated, essentially, what are your main stories that you're going to worry about? Well, first, maybe give me one that's physiological. That's right, Sharon. In neonates, particularly the more premature they are, because they don't express well UDP glucuronidase but that's physiological. So maybe I'm more excited about what's not physiological. So maybe similar to this, it could be some genetic diseases where there's a problem with UDP glucuronidase, right? Ah. And you know there's two possibilities there. Decreased or literally absent. And genetic deficiencies in the UDP glucuronidase gene, UDP glucuronidase, it's decreased in an autosomal recessive disorder that we call what? Gilbert syndrome. There you go, Ala. Gilbert syndrome. Whereas it's absent in an autosomal recessive disorder that we call Crigler-Najjar, particularly Crigler-Najjar type 1. Well done, Ala. Sharon, were you about to put Crigler-Najjar too? Because that's good, if you were. Now, in Gilbert syndrome, it's really mild, and essentially, it's a healthy individual, and it's precipitated by stress, like physical stress, infections, anything where there's going to be increased release of heme-containing protein. For example, physical stress with some myolysis releases some myoglobin and more heme than you can handle. An infection with activities of catalase, peroxidase that are heme-containing, greater activity of splenic macrophages which digest hemoglobin are going to cause, again, an overweight in heme to be catabolized to bilirubin, and then if you can't conjugate, it'll build up. So you'll see indirect bilirubinemia. In Crigler-Najjar, in type 1 Crigler-Najjar, there is a complete absence, so there is kernicterus in the neonate, and therefore it's potentially fatal in infancy. Where in the brain does bilirubin love to deposit? Basal ganglia. Perfect answer, guys. Absolutely. So a nice spot to see the actual deposition. Otherwise, indirect bilirubinemia doesn't have to be genetic deficiencies in UDP glucuronidase, but it could be genetic deficiencies in enzymes that could do what to red blood cells? Like in pyruvate kinase deficiency and G6PD deficiency, or otherwise structural protein issues like in sickle cell anemia, in hereditary spherocytosis, elliptocytosis, or autoimmune type of issues? Absolutely. Or otherwise, you might have the big family of hemolytic anemias. And so hemolytic anemias, of course, there's so many of them, if you have chronic hemolysis in particular. So here, what we would do is check the hematocrit, obviously, check for reticulocytosis, showing you the bone marrow trying to replace. Of course, check mean cell volume. For example, if it's small, maybe it's a hemolysis because of a thalassemia, if it's less than 80. If it's anywhere normocytic between 80 and 100, that's where most of our hemolytic